Hello and good afternoon to everyone. This is Manashwi welcoming you all to our e-learning session. So EyeBids e-learning session is an interactive program where we discuss optometry topics, and today we have Mr. Diwakar Rao who is going to talk on the topic Advent of New Theories in Neuroscience and Amblyopia Therapy. First of all, I would like to start by giving an introduction to Diwakar sir. Mr. Diwakar Rao graduated Bachelor's and Master's of Optometry from prestigious Lotus College of Optometry. He is currently working as HOD at Sankara College of Optometry, Bangalore. He has specialized in vision therapy. Mr. Diwakar has vast experience in teaching core optometry subjects, especially binocular vision and dispensing optics. He has been speaker for many national conferences and has also presented several papers at national and international level, and he guides optometry students in several projects. He has keen interest in optometry education with a teaching experience of over a decade. So on behalf of EyeBids team and our entire audience, I would like to welcome you, sir.
Thank you, Manashwi, for a brief introduction. I'd like to thank the EyeBids team and special thanks to Satyam for inviting me for a talk on binocular vision about the amblyopia therapy. Thank you, all the organizing team. And let me start with the topic. In this topic, we're going to...
So just a small issue. So I would like to request all our audience member to please switch your microphones off till the presentation is going on. So any questions that you have can be discussed in the chat box, the conversation box, and we will discuss it with sir after the presentation is over. Please switch off your microphones.
Thank you. Let me start with the topic for today, and the topic for today is amblyopia therapy. And thank you for the introduction, Manashwi. So we're going to talk about amblyopia, which is the classical definition of amblyopia, which was known as the visual acuity which has got decreased, or the visual acuity is reduced. So this was the one of the definitions earlier, and most of us as a layman know as amblyopia as the weaker eye. These are all the older definitions where we talk about difference in visual acuity greater than 1 line or 2 line difference in the visual acuity with best corrected glasses or contact lenses. So this was first clinically identified in 1713, and occlusion therapy started in 1720. Now we are in 2020, and still occlusion is followed, and it's a almost 300 years old concept of patching being used, or occlusion therapy is being used. So we're going to talk about new advented theories and new approved theories with a scientific based analysis which shows that there are much more evidence than compared to the traditional occlusion therapy, which is almost 300 years old. So the functional definition, which is given by Quifred, which says that it's an unilateral or a bilateral condition where the best corrected visual acuity is poorer than 20 by 20 or 6 by 6 in the absence of any obvious structural or pathological abnormalities in the eye. So this was given in 1991. So now the latest definitions are the behavioral definitions. So it is to understand the treatment amblyopia in the most effective way and understand the neurology of amblyopia. So basically we all know amblyopia is just a decrease in visual acuity, but that is only the top of the iceberg. So if you all remember the movie Titanic, so the issue was caused by the iceberg, and what we see is above the sea level, but the problem is much below the sea level. So amblyopia is also same way. Visual acuity is one of the sign, but the problem is much more beyond up to the visual cortex where the brain is not able to perceive it. So amblyopia as a behavioral definition, amblyopia is a problem primarily with binocular competition. So it is not a problem with the eye, it is a competition between the eye which is causing this problem. So competition can be explained in simple terms. Example, you have a mother and two children, a twin childs, and the competition which occurs between these two childs. Example, mother is more speaking to one of the child and the other child is being left alone. So then what will happen is the competition becomes abnormal and one eye becomes dominant than compared to the other eye. Example, the mother is showing an affectionate towards one child, the other child is not showing the affectionate. So one child become favorite to the mother and the other child is left alone. So you can compare these two children as the eye and the mother as a brain. So the dominance and the active suppression increases and increases further. So you keep on dominating the eye, which is good, will start dominating about the weaker eye. And it goes into such a way that the weaker eye will go into suppression because the mother is not paying attention towards the child. So here the mother, we are referring to the brain. Brain is not giving her attention towards the eye. So the amblyopic eye is not the weak eye. Suppression is an active process. So because the brain is suppressing that image, and you can see that through the which is given over here, the image which is captured in the visual cortex. So the eye which has the weaker eye, you can see the image how it is being captured, and see both the eyes when it is working together how the image is being captured in the visual cortex. So this suppression is an active process which continues to happen throughout the life, and the child with a weaker eye will not be able to express that. And amblyopia is the brain, it is not in the eye. The problem is with the brain and not with the eye. So whatever the treatment we're thinking about, or whatever the etiologies we're talking about, is with the eye, but it is not with the eye, it is a problem with the brain which is perceiving it. So it's a binocular problem which is manifested monocularly. So as we said, the eye which is weaker, it is being overtaken by the good eye, and the visual cortex is perceiving the image from only the good eye. So the behavioral definition is reduction of monocular visual acuity is only the symptom of the true problem. And it is not an eye with the amblyopia, it is a child with an amblyopia. So the amblyopia is not with an eye, the child is having an amblyopia here. So you have to treat the child rather than treating an amblyopic eye. So amblyopia visual abilities or deficient visual abilities. So we see the difficulties with the visual acuity, that is one of the sign. They will also have difficulty in movements and fixation, such as they will have unsteady and eccentric fixation. And saccades and pursuits are affected, because the ocular motility is affected. And along with that, you also see the accommodation skills such as amplitude, accuracy, latency, all these are affected in a patient with amblyopia. So what we see is only visual acuity. There are much more problems beyond this. So start looking towards eye movements, eye fixations, and also accommodative skills. If you just treat a patient with a poor fixation, he has an eccentric fixation, you try to treat that patient with an amblyopia therapy, you will not see an improvement because he's not using the fovea, he's using an extrafoveal point. So look for phenomenon such as crowding phenomenon. Most of these children with amblyopia will have a crowding phenomenon. So what all the evaluation you have to perform when you are doing this therapy is amblyopia assessment. Whenever you do amblyopia assessment, look for visual acuity is one of the sign. So if you're assessing the pediatric visual acuity, check the pediatric visual acuity with the pediatric charts available. A few of the pediatric charts which are shown here. Look for a Bruckner's sign. So Bruckner's sign will show that there is a difference in the light reflex between the right and the left eye. Possibly the patient may have, or the child may have, a refractive amblyopia, an uncorrected refractive amblyopia. So look for the difference between the reflex in the right eye and the left eye. So compare this with a simple test like a Bruckner's test, which you can perform from 50 centimeter to 1 meter distance with your direct ophthalmoscope. Illuminate both the eyes with the direct ophthalmoscope. Look for the reflex in the peephole of the direct ophthalmoscope and see the reflex and compare both the eyes reflex. If it is equal reflex, it is a good. That means there is a possibility of amblyopia is less. Whenever you find there is an unequal reflex, there is a higher possibility to have an amblyopia. So give attention to these patients who have a difference in the light reflex. Perform subjective refraction. Give a best corrected glasses. So once you assess that, look for macular fixation. So you can do a simple test such as visuoscopy, where you can use a direct ophthalmoscope grid in the direct ophthalmoscope. Ask the patient to look at the light source of the direct ophthalmoscope, and you can see the fixation of the fovea. Is it fixating on the grid, in the middle of the grid or not? Example, you can see that over here, the fixation is checked, and you can see the white dot, which is the foveal reflex, is exactly at the center of the grid. And in this case, you can see the foveal reflex is eccentric. So that shows there is an eccentric fixation. So check for any possibility of squint, rule out the squint. Is it an unilateral or is it an alternating type of squint? So always try to use a translucent occluder so that you can see the deviation under the cover, and check for suppression as we discussed. So there is a very high possibility that the patient may have suppression. To rule out suppression, you can perform a simple test like a Rutherford dot test. If you don't have a Rutherford dot flash with you, you can do a very simple test like a 4-prism base out test, where you can place a 4-prism base out in front of the eyes, and with a target given for the patient, see for a movement of the eye. If you see a movement of the eye, that shows there is a no suppression. If you don't see any movement of the eye, possibility of having a suppression. A test like stereopsis, because the suppression is set in, there is a high possibility that stereopsis, that is the third grade of binocular vision, is poor. Assess that with any of the chart which is available with you. Record stereopsis in these patients before you start the therapy. It can be one of the indicator to see how visual acuity and stereopsis has been increasing. So tests such as ophthalmoscopy, slit lamp biomicroscopy, visual field assessment, and armsless grid to be performed to rule out any pathologies which are present, which is causing decreased visual acuity, to rule out that. So coming to the treatment options. So we have various treatment options. The list of options are present, and a couple of options I've tried to put all together in summarize in one over here. So let us go in detail one by one. What are the treatment options available for patients with amblyopia? So the classical treatment option, which I said, the 300-volt method of assessing treating amblyopia, was full-time occlusion or a part-time occlusion, where you occlude the child one of the eye, that is the good eye, and make the child to use the poorer eye. So this is one of the treatment options which are followed. So full-time occlusion. Disadvantage of this occlusion is full-time patching eliminates the possibility of developing binocularity. You're not letting the binocularly function together. You're just working on monocularly. Remember, we told it is not a problem with the eye, it is a problem with the brain. So when will the brain work is when you make them to work together. So second disadvantage of occlusion would be it reduces the child's field of vision. You're making to look through only one eye, the field of vision is decreased, and full-time patching is difficulty to maintain for both the parent and the child. Most of the time the child doesn't like to wear the patching, or the child denies to wear a patch. In those conditions, the parents will try to push. He may or she may wear the patch in front of the parents, but when the child goes to the school, that is where his majority of activity is happening, the child may not insist wearing the patch. So other disadvantages, patching alone as a poor success, it just doesn't work very well. So the reason, as we discussed, it doesn't let your binocularity to occur. So patching for amblyopia has shown disappointingly modest improvement in visual acuity. This was quoted in 2006 British Journal of Ophthalmology by the authors. So they have shown that there is a very modest of improvements by just using patching as an option of treatment for amblyopia. So coming to the prescription of glasses, the optical prescription is to be very optimal whenever you prescribe glasses. So classical prescription was to prescribe maximum plus or cycloplegic refraction, whatever you get through cycloplegic, because these children may not be able to give you a subjective response. Full correction of anisometropia or astigmatism. Then the goal is to provide maximum visual acuity by providing the best corrected glasses. But what is optimal glass correction is we don't know, because the child is not able to give you a subjective response. Even though you may find it to do a objective retinoscopy and deduct your working distance and prescribe those glasses, may not be those glasses optimal. So the classical treatment is a weak link of classical treatment is full-time occlusion and full optical correction. This is what was used earlier. So this ignores the neuroscience research and treats amblyopia as a monocular problem instead of binocular problem. So how do we break this chain? So example, you have a case of high anisometropia, full optical correction you're given. Say high anisometropia, you can see in this child, one eye the child is wearing a plano glass, other eye is using a very high plus lens. You can see the eye between the right eye and the left eye high plus you have used, looks like magnified, and it's an anisometropia which is you're trying to correct with the spectacles. The best possible treatment would be to use a contact lenses rather than giving a glasses. So this may increase suppression and make binocular problem worse. So the suppression is the child will not prefer to use the left eye in this case. So that may lead to good visual acuity in the right eye, and left eye slowly starts getting into suppression. An ideal treatment option would be in this case to give contact lenses in both the eyes. If there is a less correction in the right eye, just give spectacles, and the high glass correction in the other eye to treat with the contact lenses. So this is what we have been doing, best possible glass correction, and patch the good eye. Which is the good eye? The good eye is the right eye here. Patch the good eye of the right eye and make the patient or the child to look through the left eye. But that treatment will work as a monocular treatment. It doesn't work anyway binocularly. So behavioral treatment option is in these patients, how do we supposed to treat? It's a neural treatment, the neural optometric treatment, what you're trying to talk about. So the key concept is in this treatment, what is the key concept in the neural aspect of treatment amblyopia. So we are working on brain and not on the eyes. So try to give therapies as much as possible binocularly rather giving monocular therapies. So there is a publication which has been published on neuroplasticity. In that publication, it has been quoted that we are in the new era of neuroscience, and every day more applications are being investigated for brain rehabilitation. So neuroplasticity is reality that nobody now denies. So everybody knows that neuroplasticity works, and this publication which has been published, yes, it has been approved and it has a scientific base. So the key concept is not to use the old outdated ideas or the myths which is 300-year old. So try to switch on to the newer treatment options of neurosciences. So neuroplasticity and neurogenesis exists throughout the life. So that means a child who is born now, a day one baby, to your deathbed. So neuroplasticity and neurogenesis continues to happen. So neuroplasticity is a process by which neurons can increase their connections with other neurons through sensory simulations, learning and experience. So we earlier thought as once a nerve is dead, it cannot refunction. But neuroplasticity says that nerves can reconnect each other and they can function back by stimulating learning and by experiencing. So what is the scientific base for optometric vision training is a study published in 1992 by Vick and Wagner, Cotton and Scheiman, published in Optometry and Visual Science. It says that the sequential treatment planning using lenses, occlusion and active vision therapy can yield substantial and long-lasting improvements in visual acuity and binocular functions at any age. So this is a published data which is available and shows that neuroscience and neuroplasticity can be easily achieved by simple treatment of lenses, occlusion and active vision therapy, all combined together. So the more key concepts to understand in a simple way, we all have known this story of 7 Lilliputians where the Cinderella is dead and she is not alive. We all thought that she was dead and the brain is not functioning. She's gone into a deep sleep. So she has to be awake and she was not getting awake. So what did awake her? So how did you awake? Study published in 2007, plasticity on neurosensory system. This is a critical period re-examined. So in that study, they have published saying that elevating neural inhibitors in adulthood with drugs or training paradigms may unmask the full capacity of lifelong learning. So that means lifelong learning will happen. So there is no stage where we can stop. So incidental visual experiences cause a synaptic inhibition of input from deprived eye, and that reduces as such inhibition results binocularly. This was published in 1976. So what is the key concept here? There is a Cinderella's on a deathbed and she is not awake. And how do we make her to awake? So the awake was here the kiss. So what is the kiss? The kiss here is the behavioral therapy which we are talking about. So the kiss made her the neurons to get activated. And what is that kiss which we are talking about is behavioral vision based on neurosciences. So this is what we are looking at, and we are trying to treat that by using this. So how do we treat with help of behavioral treatment rather than the conventional treatment options? So behavioral treatment has 3 key concepts. One is behavioral lens prescription. So the next one is behavioral use of occlusion. The third one is behavioral optometric vision therapy, which works on monocular fixations in binocular field and binocular. So what is behavioral lens prescription? So we were discussing about this previous case where I had discussed about a child being prescribed plano in one eye and a high plus in the other eye. And you saw that the high plus which was prescribed, that eye was getting into suppression, and slowly the child will go into suppression. So how do we treat in this case with the behavioral lenses? Prescribe the lens. Example, if the child is having plano in one eye and a plus 10 in the other eye, try to prescribe the plus, not the maximum plus, but the plus which is required for binocular activity to function. So you can assess that with the stereopsis and see, example, with +7 diopters, the binocularity is able to achieve. So you can assess through stereopsis or a Wordsworth dot test and see that if +7 or +8 is sufficient enough, you can prescribe that rather than prescribing directly a +10. So that is a behavioral lens prescription which we're talking about. Rather than going for old concepts of maximum plus correction, you can give a behavioral lens prescribed based on binocularity. So pay attention here. So that is neuroscience research shows that whenever you prescribe, look for binocularity, is it achieved? Example what I gave was the previous example. Instead of giving a plano and +10 in the other eye, so the +10 can be decreased in such a way that stereopsis or stereo acuity is maintained. So example with +7, the stereo acuity is same, and even with the +10 it is same. Better to prescribe a +7 rather than a +10 because binocularity is much better than this. If you prescribe a +10, the eye which is having a +10, that will slowly go into suppression. So the next key concept was, first one was prescription. So the second key concept is about occlusion. How do we occlude the eye? So the earlier occlusion procedures were using complete opaque patches where you can completely patch the eye, and that patching will make sure that the eye is completely occluded. But instead of that, so we have to think of behavioral occlusions. So how this can be achieved is by using a method such as a Bang-Getter foil, so the filters can be used. So how does this help? So this helps to maintain binocularity. So how can we achieve this? Example, if the child with a good eye, the visual acuity is 6/6. The eye with an amblyopic eye, the visual acuity says 6/18. So there is a difference of 3 to 4 lines between both the eyes. So what we usually do in traditional method is patch the good eye which has 6/6 vision. That is a complete opaque patch so that the patient is not able to see through that. And you make to work to the eye which is poorer eye or the amblyopic eye, and through that the visual acuity is improved. So instead of that, the behavioral treatment talks about occluding the good eye with the Bang-Getter filters. So these filters are available with different grades. So they are available with grade 1, grade 2, grade 3. Example, if grade 1 decreases the visual acuity by 1 line, so this child has a visual acuity of 6/6 in one eye, 6/18 in the other eye. So you can use a Bang-Getter foil which decreases the visual acuity in good eye to 6/24 or 6/36, so that the child is using the poorer eye, that is the amblyopic eye, to look at the target, and still you are able to achieve binocularity. So in this example, with the 6/6 visual acuity, I will give a Bang-Getter foil of a grade 4 or a grade 5. which will decrease the visual acuity to 6 by 24. So if the visual acuity is 6 by 24 decreased in the good eye, the patient is forced to use the amblyopic eye, that is the eye which has 6 by 18 vision, and still the patient is able to do binocularly. So that will be a good option rather than giving a full occlusion or an opaque patching. Rather than that, partial occlusion will be a better option, and partial occlusion can be achieved with these Bangeter filters. So what if I don't have this Bangeter filters? What is the other option? So other option is you do get this crotch tapes. So this crotch tapes can be put on the glasses which have the good visual acuity. Over the glass you can put this, and you can leave nothing to be put on the other side so that the patient is able to use the amblyopia eye. So we do practice this as an behavioral patching option. So this is the second key concept. So let us look at the third key concept. So the third key concept is, now you're given the best correction that is based on the binocular concept on behavioral lens prescription. Second, you're given a partial occlusion rather than a full occlusion. You're making them to work binocularly. Third, you're working with an active vision therapy. So you're trying to work binocularly now. So try to give therapies which works on binocularly. So if a child has poor monocular fixations, you can work with these uh, monocular fixations, you can improve. Then you can work on saccades and pursuits, because we also discussed ocular motility is also affected. Along with that, we can also work on convergence and divergences, and also work on accommodation. So we have various aspects to improve, not only vision, along with that binocularity, achieved through ocular motility first, therapies which works on ocular motility, such as you see a peg rotator over here, a manualized one, the motorized ones. Then we're also using a Brock string to improve urgences. We are using here the vectographic targets to improve on divergences. So these will all improve on binocularity. So what we are trying to do with this is we are trying to marry the right eye with the left eye. So which is keeping them married? So the ring or the Mangal Sutra which is being used here. So that is the uh, connection between both. So we talked about the three key concepts. One is the lens prescription based on the behavioral aspect rather than giving my maximum plus or minimum minus. So work on binocularity, see stereopsis as a indicator when you're correcting. So look for occlusion as a partial occlusion. So that is through Bangeter foils, and work on active vision therapy. First work monocularly, improve monocular fixations in the binocular field, that is MFBF, then work binocularly. So such therapies which works on uh, binocularity, which we talked about, ocular motility, vergence therapies, and accommodation therapies. So if you work on these three key concepts, are much better than the traditional just occlusion or a patching or a best corrected glasses and just giving a patching therapy as an option. Instead of that, so try to work on it. So how do we achieve this? By binocularity, sensory fusion, and stereopsis maintained, and this is gained by vision therapy. So you can do that with the help of vision therapy, and you can gain this all possible goals which can be achieved. So stereopsis is one of the major indicator in the case of amblyopia. Stereopsis is not just a test of depth perception. It is also talking about how the quality of binocularity is. So it is basically talking about the sensitivity probe into the quality of binocularity. If stereopsis is poor, the binocularity is poor. If stereopsis is good, the binocularity is great. So stereopsis is a single best indicator for overall function of both sensory and motor portion of visual field. And this has been published in a data in a 2006, the clinical refraction. In your Borish book, we have this. And it is one of the barometer of binocularity and visual functions. It is taken as one of the greatest indicators. That means if you're treating any patient with amblyopia, first check visual acuity along with all the parameters what we discussed, and also stereopsis, record stereopsis. And when you're treating along with visual acuity, also keep a measure of stereopsis, how stereopsis is improving over a period of time. So that will be a clear indicator that how your therapies are going on. So to summarize and to conclude this session, so don't forget to treat the whole child or an adult. So remember, we compared the two eyes as two children's and brain as a mother. So if mother is not showing an affectionate towards one child, that child feels that he is being suppressed. So that is what is amblyopia is occurring. So we have to not talk to the child saying that you have to behave well, but instead we have to talk to the mother, that is the brain, to accept that child. So that is the eye, and work on the brain. So you're not treating amblyopia, you're treating a person with amblyopia. And you also need to work on any problems in learning, motor, bilateral integration, perception, and various aspects of these children of amblyopia. So you have to treat all those concepts. So classical treatment of amblyopia just treats eye, and eye is not an object which is floating in the space. So it is connected to the visual cortex. So classical treatment is not based on new neuroscience researchers. These concepts exist. So I like to conclude over here. So thank you for giving me this opportunity. If any questions is there, we like to take up, and
by maintaining the binocular balancing, you are stimulating the neurons. Huh? How does it work?
Not binocular balancing. So, example I gave an option in the earlier case was a child with anisometropic amblyopia. So, in that case, if you prescribe the full correction of anisometropia, there is possibility that the brain may suppress that eye which has the high prescription. So instead of that, what we can do is we can keep stereopsis as an indicator and see what best correction would be required to maintain stereopsis. Say example with one eye plano, other eye plus 10, and if the stereopsis is say 300 seconds of arc, and say with plano and plus 7, the stereopsis is improving to 100 seconds of arc. So that means the stereopsis, it's an indicator of binocularity. So binocularity is better with plus 7 and plano in the other eye, rather than prescribing plano and plus 10 in the other. So this is what I was talking about, behavioral prescription aspect. That is one indicator. Second, instead of just patching the good eye and make the poorer eye to work, so give a partial patching like this bilateral foils. If that is not there, you can use a tape which can occlude that eye to decrease the visual acuity, but still he is able to see one line above the poorer eye's visual acuity. Then work on binocularity. So this is not what I'm talking about, binocular balancing. So that is totally different concept.
Good afternoon, Diwakar sir. I am Anshu here.
Yes, tell me.
Sir, my question is that if we give the maintain the binocularity, if our concern is the stereopsis, right? To
Correct.
maintain the binocularity, right? So
Yes.
is it visual acuity also improve in amblyopic eye? We are considering the visual acuity. Actually, patient wants to increase the visual acuity. Patient compare the visual acuity first visit to last visit.
Okay.
Yes, patient actually, what does patient wants? Patient wants whether my child visual acuity is visual
Yeah,
performance
Himanshu.
increase or not.
Yes, Himanshu, your question is correct. But Himanshu, patient doesn't know that he has a problem with visual acuity. So it is we are the one who are talking to the patient that you have a problem with the vision. Okay. As I discussed in the initial slide, visual acuity is just the iceberg of the problem. So it is not the true problem. So the true problem lies much beyond this. So what is the true problem much beyond this? So we are talking about uh, binocularities like pursuits, saccades, accommodation, all
Hmm.
these are affected. So if you just do a traditional patching therapy, yes, you can improve visual acuity, but you're never making both the eyes to work together. If you never make both the eyes to work together, there is always a possibility the eye which has improved the visual acuity, after a period of time when you stop the therapy, there is a chances of regression. Regression is, say example, you had a patient of 6 by 18 visual acuity and you improved the visual acuity, say 6 by 9. And after you
Okay.
stop the patching therapy, you would have seen most of the cases, the visual acuity decreases back to 6 by 12 or over a period of time back to 6 by 18. Have you seen this? Have you observed this with the traditional patching therapy?
Yes, sir. Yes,
Yes. The
yes, sir.
reason
Yes,
is
sir. Yes, sir. So many
you
times.
are never making them to work together. So once you make to
Okay.
work together is nothing but binocularity. So how can you do that? Is when you start giving binocular therapies. So as you indicated, visual acuity is one of the signs of amblyopia, but the problems are much beyond visual acuity.
Yes, there are so many problems like accommodative problem, stereopsis, and
Sure.
saccades problem.
Yes.
There are lots of
So what
problems.
you can do is
Okay.
henceforth, whenever you get any patients with amblyopia, along with amblyopia, please check for centration, check for pursuit saccades, check for these accommodation amplitudes. Most of these will be affected in those patients. So if you treat only visual acuity,
Thank you, sir.
you're not looking at this as a treatment option. There is a higher chances there is a regression is possible, and the patient will come back saying that I don't see any improvement.
Yeah, one more question, Diwakar sir. Hello, this is Pratik sir.
Yes, Pratyush.
As you just gave an example of having plano and +7 in other eye, and the primary indicator is stereopsis. What about diplopia? I mean, we consider the all grades of BSB, or only will consider the the stereopsis?
Yeah, so I had given you two concepts to be considered when we do behavioral glass prescription. One is stereopsis and one more is Burford dot test, which is
Yes.
checking suppression and as well as diplopia and fusion. All the three things have been assessed over here. So first thing is you have to check fusion is achieved with the best corrected glasses. And once the fusion is achieved, then you check for stereopsis. If fusion itself is affected, then the correction what you have prescribed, you have to relook into that correction. You may not have prescribed the proper correction. So if diplopia is occurring, then you have to go back and recheck. And in those cases, instead of prescribing glasses, you may have to go and correct with contact lenses, will be a better option. Yes,
Yes.
Pratyush is
Okay, I hope that answers
Yes. Yes. Thank you so
the
much.
question. Okay, sir, shall we discuss the questions in the conversation
yes,
box?
yes.
Okay, so Ms. Ratna has a question. Should we prescribe the power we get by doing retinoscopy to a child in amblyopia?
Ratna, the concepts now have start looking at the behavioral concept of prescription. So This concept may be new for all of us because we have been taught to prescribe is whatever we get through a retinoscopy. So what we do, example, we have a pediatric, we have a child and whom we see that there is an anisometropic amblyopia. What we do is we do a cycloplegic refraction and we give a best corrected glasses. And what we do is we give a maximum plus or a minimum minus as a prescription. And we prescribe the glasses according to that. But I would like you to look into the concepts of behavioral prescription where you can consider stereopsis as a concept or Rutherford dot as a concept of indicator. But it's difficult to assess stereopsis and Rutherford dot in a child who's not able to give a verbal response. But the children with a verbal response, yes, behavioral prescription becomes good option. So in those cases where we don't have a behavioral the subjective responses, in those cases try to look for indicators such as look for a cover test. Is there any phoria or tropia is being left over after giving correction? Check for these as an indicators and try to prescribe the best possible corrected glasses. And we don't know what is the best possible corrected glasses because we are relying on our retinoscopy and we are not able to assess the subjective response in these children.
I hope that answers your question, Ms. Ratna. So similarly, the other question is from Ms. Ashia Sheikh, and she asks that her institute's ophthalmologist prescribes only occlusion, and how can we change the trend?
Yes, Ashia, right?
Yes, sir, Ashia.
Yeah, Ashia, to answer your question, yes, we have to get updated. So whatever I have quoted in this study, these publications are available. So these are scientific evidence-based studies which have been published, and there are much more latest studies which are also there. We can show this as an evidence base, and if you can convince the your management and get into this newer modality of treatment would be a better option.
Sir, same problem with us also. That is a good question. Actually, the same problem with us also. So, can you share the references which we can show if they
Definitely.
actually they
Yes,
say
Iman. So I'll be able to share this references which have been published and full text articles of these. So,
exactly, sir.
which you can download it and share it across with your management.
Okay, thank you, sir.
Okay. Similarly, sir, Ms. Rojita has a question. Is there any expected stereopsis value while prescribing lens correction?
Expected?
Stereopsis value.
Okay, expected stereopsis value, the normative stereopsis is 40 seconds of arc, but expected stereopsis value, like in the previous example I said, with the plano plus 10, the stereopsis was 300. With plano plus 7, the stereopsis increased to 100 seconds of arc. So after that, changing to plus 6 or 5.5, the stereopsis didn't make any change. So I would have prescribed a plano plus 7 as a correction rather than plano plus 10, which has a decreased stereopsis. So what we have to see is keeping stereopsis as an indicator and fusion as an indicator. See that what is the maximum stereopsis is achieved with the best possible correction is one of the way. If the stereopsis doesn't make any changes beyond further decreasing or increasing the prescription, so then you can stop over there.
Okay, I hope that answers your question, Ms. Rojita. So similarly, Mr. Ajay Kumar Ray has a question. How can we determine optical best correction on a child who are not able to give subjective response?
The same question was asked by Ratna, right? Similar question. So question is about how do we give a best correction child whose subjective response is not there. So that's what I said. You have to rely on your retinoscopy values, and the best possible would be to do a cycloplegic refraction. Or if the child doesn't insist or let you to do a cycloplegic refraction, the best possible would be to use Mohindra retinoscopy, which is a near retinoscopy, which is considered to be as equivalently good to a cycloplegic refraction. Based on that, we have to prescribe the glasses and see over a period of time, and once the verbal response you're able to get, and try to use the stereopsis as an indicator and prescribe best corrected glasses at that time.
Thank you, sir. So Ms. Arka Ghosh has a case, I'm assuming. So a patient of age 27 has present amblyopia on right eye with visual acuity in left eye 6/6, and I'm guessing right eye 6/60. She has mentioned left eye 2 times. In objective refraction on right eye, I have found plus 3.25 diopter sphere, but on that power, no changes in vision. So what should I go for? Do I give him the correct?
Yes, we have similar cases, Arka Ghosh, where this patient has been diagnosed as amblyopia earlier itself, but they never prescribed any glasses, saying that you're 27-year-old and now there is no treatment options are available, or even if you treat also, you don't see any improvement. But it's not the sciences which are saying now. As I showed in one of the slide, uh, the science have been proved that neuroplasticity occurs throughout the life, and our colleagues in physiotherapy who are working on neuroplasticity, basically nothing but a patient who has got a stroke, and the stroke is occurred in the brain, and they're working through physiotherapy and get back to the person into the normal through physiotherapy. So that's working on neuroplasticity, and we see physiotherapy is working for so many years, and so many successful cases are there. So similarly, based on that, the studies have shown that neuroplasticity can be achieved at any age. So in this example, what you have quoted, left eye 6/6 vision and 6/60 vision, and even after giving plus 3.25, the visual acuity remain to be 6/60. I will still insist to go on prescribe the glasses in this case. And yes, adult amblyopia can be treated. So it can be treated. Consider this as a patient of amblyopia. Yes, there is no improvement in the visual acuity, but prescribe the glasses, go ahead, plano in one eye if the other eye doesn't have correction, and plus 3.25 in the other eye. So keep a stereopsis as an indicator after prescribing this, and start giving amblyopia therapy and see with the follow-ups how stereopsis is developing. You will also see visual acuity will improve. And yes, there are cases which have shown that adult amblyopia is treatable.
Thank you, sir. I hope that answers your question, Ms. Arka Ghosh. Similarly, Ms. Pavitra has a question. If the child has autism, will they cooperate for therapy, and how do you manage if they are not cooperative?
Pavitra, the amblyopia cases are completely a different set of patients or different group of patients, where uh, the complete aspect of treatment is different in those cases. We will try to prescribe the best possible glasses through only your retinoscopy, what you have achieved. We are not able to get a subjective responses in these cases. With a mild autism, yes, we are able to get. With a severe and moderate autism, you may not be able to get. And if the child is a non-verbal child, it becomes even more difficult. So the treatment options is completely different in autism cases than with amblyopia than compared to a regular amblyopic cases.
Thank you, sir. So similarly, Ms. Arka Ghosh has another question where she asks if frosted glass may be used on partial occlusion.
Yes, Arka Ghosh, I forgot to mention this in my presentation. Yes, frosted lenses are one of the options of treatment as a partial occlusion, where you can use frosted lenses as one of the occlusion option. So in these frosted lenses, what we can do is we can frost the lenses in such a way that it decreases the visual acuity. If you frost too much, it can decrease visual acuity to the higher level. So frost the lens as less as possible. But disadvantage of frosted lenses is once a lens has been frosted, you cannot reuse that. So instead of that, using a tape, the scotch tape would be a better option, because once you remove the scotch tape, the lens which is there, it can be reutilized. Or if you want to increase the density of the occlusion in that eye, we can put instead of one scotch tape, we can put two scotch tapes on each other. So that can increase the density of the scotch tape. Frosted lenses, yes, it is an option, but the difficulty is if you want to change the level of frosted, it is difficult.
Thank you, sir. Similarly, moving on to the next question, Mr. Murli Shah has a question. How long do we continue partial occlusion, and in what sessions do we should give?
Yeah, so partial occlusion should be achieved still the visual acuity gets into equal or one line of difference if it is there. Up till there, you can consider partial occlusion. Later on, you can start working on binocular.
Thank you, sir. I hope that answers your question, Mr. Murali Shah. Similarly, Ms. Rinki has a question. Can you explain to me how to document in worth 4 dot, and should worth 4 dot be done for near and distance both?
Rinki, how to document worth for dot? You have a worth for dot target which is there in your visual acuity chart. Use your red-green filters in your best corrected glasses over that, and see if the patient or the child is able to see 4 dots. That indicates there is a fusion. If only 2 dots or only 3 dots are seen, that indicates the either eye is suppressed, or if you see your 5 dots, there is a chances of diplopia. Yes, it has to be done for near, it has to be done for intermediate distance, and it should be also performed for distance. All the 3 distance you have to record. There is a possibility where the patient may have fusion for near and suppression for distance, and also possibility of patient may have fusion for distance and suppression for near. So it is possible. So it is better to examine at all the distances.
Thank you for the answer, sir. Similarly, Mr. Tabriz has a question. Do we need to change the filters according to the vision improvement?
If I'm not mistaken, the filters what Tabriz is talking about is, I think, the Bangeter foils. Yes, the Bangeter foils are available in different grades. Example, grade 1 decreases the visual acuity for 1 line. So if you want to decrease the visual acuity by 2 lines, you'll go for a grade 2 or a grade 3. And these filters can be removed and stick onto the glasses. So they are available commercially, manufactured by 3M company. And it is similar to the way which we stick these Fresnel prisms. So these Bangeter foil are also available, and yes, they are available with the different grades.
Thank you, sir. I hope that answers your question, Mr. Tabriz. Similarly, Mr. Keshav Acharya has a question. Following behavioral glass prescription, if we are undercorrecting hypermetropia, we might be able to gain the better stereopsis. Will we take accommodation in consideration for later in life after the patient is treated, or do we need to change the glass prescription later on to fully correct hypermetropia?
Very good question, Keshav. To address this, yes, first we will try to see the stereopsis as an indicator. Once that has been improved, the stereopsis has been improved as the visual acuity has improved. So then you can slowly change the prescription towards the actual prescription, what is required, but still consider the behavioral aspect of the prescription and see as a stereopsis as an indicator over a period of time. You can take it slowly. And yes, accommodation will play a role in these cases. So if you try to undercorrect plus, where the patient has to stimulate certain amount of accommodation to see the target clearer. So with the full correction, the accommodation is under the relaxed state. So this you can work when you're working on binocularity, as accommodation is one of the functions you can treat through the binocular functions. And yes, it is addressed through vision therapy, and it is treatable.
Thank you, sir. I hope that answers your question, Mr. Keshav. Similarly, Mr. Dhanaraju has a question. Is there any chances mom is showing ignorance towards both kids?
Yes, there is a binocular amblyopia. It is possible where the mom is fed up with both the children and showing an ignorance towards both the child. It is possible. In that case, it can be a deprivational amblyopia, where both the eyes has a congenital cataract, and because the sensory deprivation, both the eyes got surgery done later stage. In those cases, you can have a binocular amblyopia. Yes, later on the mother has to show affectionate towards both the children and get back them to under her love and affectionate. So yes, still we have to work on the brain to work and function both the eyes together. So in that case, instead of patching only the one eye, you'll be doing a partial occlusion in both the eyes and work on binocularities to improve the vision.
Thank you, sir. I hope that answers your question, Mr. Dhanaraju. Similarly, Nikita Nirola has a question. If we can use plus lenses to reduce the visual acuity in good eye, even if we don't have a Bangerter filter.
Yes, you're correct, Miss Nikita. That's an option where we used high plus lenses in the good eye and decrease the visual acuity in that eye. It can be done. Remember, later on, if you want to decrease the plus power and you want to get the visual acuity to improve in the good eye, then you have to change the lenses. So you have to frequently keep on changing the lenses. Instead of that, the Bangeter foils can be used, or as a simple option, which I said, the tape can be used as an option, where by keeping the same lens, only you're changing the tapes.
Thank you, sir. I hope that answers your question, Ms. Nikita. Similarly, Ms. Deepa Chavan has a question. How does Bangeter filters work, and how much hours do we need to prescribe it?
Yeah, Bangeter foils works like frosted lenses, or it decreases the visual acuity in front of the eyes. So it is kept onto the spectacle lens. It is attached onto the spectacle lens. For assessing, we can use these type of filters. So how do you get a prism bar? Similarly, there are Bangeter foils which are available for diagnostic purpose. So you can keep this diagnostic tool in front of the eye. So you can see the Bangeter foil here. And this Bangeter foil has a grading from 0 to 9. And you can keep this in front of the eye and see that how the visual acuity decreases. As you to the higher grade, it will be more frosted and the visual acuity decreases more. And based on which is required for that patient, you can prescribe that. And that grade of Bangeter foil can be stick on the glasses which has a good vision in that eye.
Thank you, sir. I hope that answers your question, Ms. Deepa. Similarly, Mr. Himanshu has another question. He wants to know what is the actual meaning of suppression and the most common cause of suppression.
Actual meaning of suppression, the best example what I gave is a mother and a two child. Other than this, I can't give a better example than this. So consider you have two siblings, Himanshu, with you. Example, you and your brother or your sister, and your mother is your brain, and your mother is showing more affectionate towards you, but not towards your sister. So what your sister will start feeling over a period of time, she will feel she is left out, and that is called suppression. So the simplest example which I can explain in the easiest way. And the common cause for suppression is refractive error, uncorrected refractive error, squint in the one of the eye, and sensory deprivation. These are all the causes for suppression, very commonest causes.
Thank you, sir. I hope that answers your question, Mr. Himanshu. Ms. Ashia wants to know if she can have the references of the scientific-based studies that you mentioned.
Yes, Ashia, as I've already mentioned to Himanshu and others, that I will be sharing this scientific-based studies.
Thank you, sir. Similarly, Ms. Rinki has another case where right eye has plus 2 diopter sphere and uncorrected visual acuity of 6/6, and the other eye has plus 7 diopter sphere and vision 6/18. So what should be prescribed in the right eye, which is non-amblyopic eye?
Yeah. So the right eye, it is a +2, which has a visual acuity of 6/6, and the other eye is the left eye is +7, visual acuity of 6/18. If the child is having a subjective uh, response, so what we can do is you can uh, keep +2 in the right eye and +7 in the left eye. Take stereopsis as an indicator and check how much is the stereopsis. So try to decrease that +7 in the left eye to say 6.5 or 6. See if stereopsis is getting better or worsen. If it is getting better, you can decrease it. If it is getting worse, better to stick to +7. So this is the easiest way or an indicator how a behavioral prescription can be prescribed if the child works.
Sir, it is not possible always the stereopsis is increased after reduction of the power in the amblyopia eye. It is not always true. It may be,
So it's always not
sir,
true.
it is
Example,
possible always.
Himanshu, if it was +2 and +7, if the visual acuity was say 400 or 500 seconds apart, even after changing the decreasing or increasing the plus correction, if the stereopsis is not changing, I would stick to +2 and +7 and see the child back, because this child may not have worn these glass correction for over a period of time. You ask them to come back and assess later on once again, and keeping the stereopsis as an indicator.
That means need to be checked the stereopsis if you reduction the power, whether the stereopsis is improving or not. If you're not improving, then we need to give the continue with the same power.
Yes, if the stereopsis is not improving, there is no point in decreasing the prescription.
Okay. Again, sir, as you said, zero power not reducing, the accommodation not improving, not stimulating.
Yes, but we are working on accommodation as a later stage when we work on binocularity. So we can work for that uncorrected refractive error through therapies.
Hopefully that answers Mr. Himanshu's question. So we'll be moving on to the next question. Mr. Manish Bhagat has a question where he asks, as you talk about behavioral optometry and it is different from others, so when to use this and in which type of case?
Yes, see, behavioral optometry is nothing but a concept of how do you understand various concepts in optometry. So the earlier concepts in amblyopia treatment option was just patching one eye and wait for the amblyopic eye to improve the visual acuity. And once the visual acuity is improved, you ask the patient to discontinue patching and you would have stopped over there. So the behavioral concept is talking about prescribing it as a concept on a behavioral lenses, keeping stereopsis as a indicator, working on partial occlusion rather than complete occlusion, because complete occlusion can also cause reverse amblyopia where the good eye can go into amblyopia, but in partial occlusion you will not have that. Then the third thing they're also talking about working on binocular. So if you work on all these concepts, this is what the behavioral concept of treating amblyopia. Similarly, there are various behavioral aspects on various aspects of treatment. So currently we are talking about amblyopia treatment using behavioral option as the treatment as an option.
Thank you, sir. I hope that answers your question, Mr. Manish Bhagat. And similarly, another listener called SS asks if we can use atropine when occlusion is not possible in an alternative way.
Yes, there are studies have shown that penalization through atropine have shown success rate, but once again, it is an alternate to a patching therapy. And remember, atropine has its side effects on the systemic absorption. So that also has to be considered. And atropine will also causes decreased near visual acuity, so which can affect the binocularity between both the eyes. And it is talking about only about the earlier concepts of patching one eye. Instead of using a complete patching, you are using an atropine uh, to cyclopregize that eye and treat. And remember, the atropine has a longer effect for almost 7 days. And one of the disadvantages, it has a systemic absorption and causes systemic abnormalities.
Thank you, sir. Thank you for that insightful presentation. I'm pretty sure that all our listeners have thoroughly enjoyed our session today. So I would like to request you to share a few words about your experience in EyeBids session today.
Today's session?
Yes, sir.
Okay. It was a great opportunity to talking to all you people, and very happy to answer all your questions. Uh, if you find the answers are not justifiable, you can get back to me. I can get references for all these. And as we discussed these scientific based studies, I will try to share it with the team which is organizing this, so that you can share it across with the team. And this session has been recorded, so you can always go back to the session and see if anything needs to be addressed. And thank you for giving me an opportunity. Thank you, Manashvi and Satyam, and the whole team of EyeBids. So thank you all, and you're doing a good work, and keeping all the optometrists and the optometry students engaged to this platform. Yes, we are all going through a difficult situation, and we don't know how long this situation is going to continue. And yes, online platforms are always great. And as an educator, it is opening our eye towards teaching aspects, so that we know we need not be physically present, and we can always do online sessions in upcoming sessions as well. So once again, thank you, Satyam.
So on behalf of EyeBids and our audience, I would like to thank you, sir, for your time and the lovely experience and knowledge that you have imparted on us today. And I would also like to thank our lovely audience for being supportive, attentive, and interactive. And on that note, I would like to end the meeting, and stay tuned for more sessions and programs in the future. Thank you.